Good afternoon, everybody. How are you? Welcome to our session this afternoon. And I'm very pleased to have you all. Where I am in this part of the world, it's 3:45 p.m. For some of you, it may be a little bit earlier or a little bit later, but I kindly welcome you to the session. You are most welcome. We are going to have 1 hour of a very, very lively session that is looking at enhancing interprofessional education, looking at interventions to improve patient outcomes and health security. We are going to have 5 wonderful presentations, one by one, from Daniel, from Sarah, from Adebola, from Omona, and from Peter. So we have a lot of exciting information coming to you, kind participants. I just want to take a few minutes to give housekeeping sessions. As we all know now, our lives are on Zoom. So please, I kindly request you to know that your microphones are turned off, and we request that you switch off your videos. However, we will turn on our videos to indicate to a presenter that they have a minute to wrap up. So when I finish speaking, I'm going to stop my video and mute myself. But if you see me putting my video on, or you see my face or my co-moderator's face, then you know you have a minute and you need to wrap up. Co-moderating this wonderful session this afternoon is Dr. Moses. With me is Dr. Moses Simuyemba. Moses, lovely to see you. How are you? And
thanks, Judy. I'm good. Good to see you too.
Good. I will be asking Moses to introduce our presenters one by one as their turn comes up. I also encourage you, please, as you listen to the presentations, to ask your questions using the Q&A box, and the chat box can also be used for interaction. So if you have a question or a comment, you can put it in the Q&A. But also, if we just want to interact and talk and make, our observations, we can also use the chat box. So these boxes are at the bottom of your screen. The chat box is the icon just next to the participants. And then we have a raise hand. If you feel something burning, I think we can allow you to raise your hand at the end and ask or contribute to the session. Please, if we do run out of time towards the end, we'll ask our presenters to look at the Q&A box and respond to questions in writing if we do not have a chance for people to ask their questions in the interest of time. So without further ado, I'll hand over to Moses to then introduce our first presenter. Over to you, Moses. Welcome, everybody.
Thank you so much, Judy, and thank you for going through the instructions there. So For this breakout session on the topic of service delivery, enhancing IP interventions to improve patient outcomes and health security, our first presenter is Dejene, I hope I pronounced that correctly, who has a presentation on applying collaboration, learning, and adaptation, CLA techniques for strengthening competency-based curriculum implementation. So please, Daniel, you may come on if you can switch on your video if possible and start your presentation. I hope Daniel has access to share his presentation and control his video. Please allow him to do so. Or perhaps we don't have him present. I cannot see his name in the list of attendees or panelists.
Perhaps, Moses, we can move to
we can move on. Yes, so I think Daniel is not there. Maybe we can move on to Sarah Kiguli on evaluation of competency-based curriculum challenges and lessons learned from implementation in one Ugandan medical school. So please go ahead, Sarah, and you can go ahead with your presentation. So that our technical moderators, I hope you have given, Sarah, there you are. Yes, I hope you have access to share your presentation and also control your mic and video.
I have. Good afternoon and good morning,
okay,
everyone.
Great.
For those in the morning, the title of my presentation is Evaluation of Competence-Based Curricula, Challenges and Lessons Learned from one of the medical schools in Uganda. Before I begin, I'd like to acknowledge the people that we did this work with, Jane Mackenzie-White and Yuka Manabi from Johns Hopkins University, Sarah Westergaard from University of Georgia, and Mowoke Gozaka from Makerere University. I'm also from Makerere University. I can't move my slide. Can someone? Okay. So there have been a paradigm shift in medical education towards competence-based education. And in this education, the population needs drive learning of observable abilities of performance of health care providers. But it requires increased logistical planning, a shift in faculty's pedagogical approach, and alignment of competencies, content, learning activities, and assessment. And therefore—
Sorry, Sarah, sorry to disturb you. Are you sharing your presentation?
I'm sharing, but I don't know if someone else is sharing.
Okay. Okay.
Can you see?
It has started now. Please put it in slideshow mode.
It is, okay.
Mm-hmm.
Evaluating the implementation of competence-based curriculum once adopted is critical. And Makerere University was established in 1922 and the medical school in 1924. And the College of Health Sciences has a history of educational innovations during the last 20 years. And we started implementing competence medical education in 2011 in the medical program. We have 9 major competency domains and 59 sub-competencies in this curriculum. A revision was done in 2016, but it maintains the major competence domains in 9 areas, as you can see, ranging from medical knowledge, clinical skills, and others. I'll not read one by one. So we did the curriculum evaluation with the aim to find out if the competencies declared in the curriculum were being assessed throughout the coursework, but also to find out how the competencies were assessed.
Sarah, we are still not seeing your slides. I'm just requesting if the Secretariat have the slide, can they show it for you? And then you just say next slide, next slide. Yeah. I'm sorry.
That's fine.
In your presentation, Sarah, and I do apologize for interrupting you, please.
It's fine.
Bernard, if you can share Professor Kiguli's slide, please.
Yes, we are about sharing.
Thank you. Please bear with us, participants. I think we were on slide number 4 or 5.
Can the slides be moved, please? Let's move on, please.
Let's go to slide number 3, please.
So those are the competence domains that our curriculum has, and they range from medical knowledge, clinical skills, and other areas, including leadership and management skills. So can we go to the next slide, please? So the evaluation was done to see if the competencies declared in the curriculum were being assessed throughout the coursework, how they were assessed, and to see if there was any gap in assessment of these competencies outlined in the curriculum. Next slide, please. So the curriculum evaluation was conducted between 2019 and 2020 in partnership with Johns Hopkins University colleagues, and the methods included developing a matrix to capture these competencies in the curricula, but also we identified faculty in charge of the courses, since the curriculum is arranged in courses, interviewed this faculty to see which competencies their courses covered and how they were assessed, and we obtained evidence from them regarding the assessment of each of the competencies and reviewed this evidence. Next slide, please. So that matrix gives you an idea about what we did. We looked at each course, the 60 courses in the curriculum, and the competence areas, 9 domains and 59 sub-competencies, and we mapped competencies against each of the courses. Next slide, please. We also had a tool to capture the assessment of each of the competencies, how each competence was assessed, the method used, but also the evidence that actually a method was used to assess each of the competencies, and mapped assessment against the competencies for the courses evaluated. Next slide, please. Next slide, please. Okay, so this evaluation was done in 2016 in the 3rd year of the cycle of the revised curriculum of 2019 It was done in 2019 in the third year of the revised curriculum of 2016. So the cycle had not yet been completed. Next slide, please. So there are 62 courses in the 5-year curriculum, and 57 of these courses were analyzed assessment, but the final evaluation was done in 54 of the courses. Next slide, please. So the categories of assessment were different as outlined from assessment during the tutorials, PBL and seminars, reports, case write-ups, assessment during practical sessions, the progressive and summative written exam, clinical assessment during the clerkship, clinical clerkship and written work, plus the clinical and practical exams and the oral exam. So a wide range of assessment modes were used. So this shows that if you look at this figure, that the written, the summative written and the progressive exam took the biggest chunk of the assessment. Most of the competencies were assessed during using those, but we can also see that 26% we have the tutorial and the seminars being assessed, the write-up, the formative assessment, but also the clinical assessment during the clinical clerkships and the practical exams in 23%. So next slide, please. So much of the assessment is on theory. This one compares assessment in preclinical and the clinical years. The first 2 years are preclinical. That's the first row, the darker color, I think the bluish. And we can see that still knowledge assessment is heavy in the progress written in the preclinical, but also in the clinical. And that's how we compare the tutorial assessment a lot in the preclinical. And if you look at number 4, the clinical clerkship assessment is only in the clinical part of the training. And maybe one interpretation is that since this was done in the 3rd out of the 5th year, we don't see a lot of the clinical assessment in the clinical areas coming in. Next slide, please. So this is the same. We can see that medical knowledge is heavily assessed. Then the clinical skills and patient care, professionalism, ethical practice. And we can see that areas such as leadership and management, population health, and health systems management, the sub-competencies under there are not heavily assessed. But it could also be because of the timing, since most of the courses that cover those aspects are done in the recess term of year 3, at the end of year 3 and year 4. So can we go to the next slide, please? Okay, that's the same information. So those are some of the sub-competences under domains 6 and 7, which we are not assessed or represented in the assessment. And I've explained one of the reasons why this may not be. The next slide, please. Chair, a lot of time is going. So we can see that a variety of methods are used in assessing each of the competency domains, both the written exam, the practical session, and assessing during the actual session. So all the domains are assessed using different methods, which I think is good. Next slide, please. So we got feedback from the faculty, some of the challenges. the large student numbers leading to insufficient teacher-student ratios and inadequate faculty development. Next slide, please. So the large student number impacts the ability to provide adequate materials during learning, the teaching space, ability to do practical sessions well, and the small group learning well, but also limiting constructive feedback, the faculty giving feedback to the students. Next slide, please. Faculty development, faculty needed or say there was inadequate development in teaching skills, instructional strategies. So the conclusions, okay, so they needed more development in how to weight the competencies to allow consistency. So all the 9 competency domains are assessed as a conclusion using different methods. There are gaps in the assessment among some of the competencies, and most assessments still occur in the cognitive and the psychomotor domains. So next slide, please. So we recommend, so next slide, we recommend that maybe there should be a review of the competencies to see, are they measurable? Is there overlap? Can the 59, some of them be consolidated? But also for faculty to find out, to see that there's better alignment of competency and assessment. We recommend the use of the online platform to help learning for the large student numbers, and maybe the opportunity came with COVID. We need to expand opportunity for faculty development around competence-based education, instructional assessment, and also instructional design and assessment strategies. So CBE is an interactive process, and we are saying that maybe formative assessment should be used more, but we are also looking at the policies at the University of summative assessment for every course. The last slide, please. So I would like to thank the funders, NIH, through our HAPPY project, and I already thanked our partners, Johns Hopkins University, who supported us to do this evaluation. Thank you everyone for listening.
Thank you so much, Sarah, for the presentation, and that was wonderful. Sharing on competency-based curriculum, which is a hot topic these days, so it's good to see what efforts you are making to evaluate that. In the interest of time, if you have any questions for Sarah, please do type them in the comments and send a message. And Sarah, you can also answer within the comments, unless we have time at the end where we'll invite all the speakers to speak and answer the questions. But feel free to type them in. Next, let's move on to the next speaker, which is who is Adebola Adejimi, sharing on awareness of HPV infection and acceptability of HPV self-sampling for cervical cancer screening among women living with HIV in Lagos University Teaching Hospital, Nigeria. So let's try as much as possible, speakers, to share our own slides so that we have control over the pace and movement, and we don't experience the delays we may have experienced with the first presentation. Please, Adebola, go ahead.
Okay. Good afternoon, everyone, and good day to you wherever you are. My name is Dr. Adebola Adejimi. I'll be presenting our research findings titled Awareness of HPV Infection and Acceptability of HPV Self-Sampling for Cervical Cancer Screening among women living with HIV in Lagos University Teaching Hospital, Nigeria. These are my co-authors and my mentors. We have Dr. Okwade, Dr. Fatureti, Professor Banjo, Professor Odeyemi, and Professor Akomo. And these are the logos of the institution that we represent. We declare no competing interest. This research was funded as part of BRAIN's Year 5 Mentor Research Grant, and the award number is displayed on the screen. My presentation will be following this outline. As a way of introduction, human papillomavirus, HPV, is a well-established necessary causal agent of cervical cancer with the highest prevalence, incidence rate, and mortality rate in the sub-Saharan African region. About 15 known high-risk HPV genotype cause approximately 95% of cervical cancer, while low-risk HPV cause low-grade lesions such as genital warts. World Health Organization, WHO, recommends programs throughout the life cycle of individuals to prevent HPV infection and cervical cancer. And this program are at the primary prevention level, secondary prevention level, and tertiary prevention level. At the secondary prevention level, WHO recommends screening of women greater than 30 years of age and treatment as needed. WHO recommends HPV testing for high-risk HPV genotype, including genotypes, those genotype 16 and 18, and other high-risk group of HPV infection. Women with HIV infection, they have higher prevalence of high-risk HPV infection with gradual progression to cervical cancer. This systematic review shows that there's higher HPV acquisition and lower HPV clearance among HIV-positive women. HPV acquisition is also higher with declining CD4 count. HIV infection is associated with higher incidence of low-grade squamous intraepithelial lesion and high-grade squamous intraepithelial lesion. WHO recommends cervical cancer screening to all women living with HIV. It recommends molecular testing for HPV infection, which is more sensitive and less dependent on the subject and training of the healthcare professional. Samples for HPV molecular or DNA testing can also be self-collected. There are several advantages of using the HPV testing or the HPV self-sampling method. And the HPV testing using self-sampling method has been shown to overcome institutional barriers and to increase participation for cervical cancer screening. It also reduces the waiting hours at the healthcare facilities. It is useful at the community level, and the results are comparable to the clinician collected samples with similar sensitivity and specificity when polymerase chain reaction is used. And it has the potential to improve the prevention of cervical cancer. Samples for HPV molecular testing that can be collected by self has been recognized by WHO as part of the self-care intervention that can reduce disease occurrence, especially cervical cancer among women. The study objectives are to assess the awareness about HPV infection, HPV self-sampling method, and cervical cancer among HIV-positive women in Lutz, Nigeria, and also to assess the acceptability of HPV self-sampling for cervical cancer screening among women in Lutz, Nigeria. These objectives are part of the objective of larger study that compare the validity of HPV self-collected sample with the clinician collected samples among the HIV-positive women in Lutz, Nigeria. The study sites of this study was actually conducted at the Adult AIDS Prevention Initiative Clinic in Nigeria, called APIN Clinic at Lutz in Nigeria, Lagos, Nigeria. It was a descriptive constitutional study, and the study population consisted of women who were living with HIV and AIDS that were attending care and treatment in APIN Clinic in Lutz. The sample size formula, Cochrane formula for descriptive study was used to calculate the minimum sample size of 227. Systematic random sampling method was used in this study with a sampling interval of 4. Every consenting 4th female patient between the age of 30 to 60 years that attended the clinic were recruited into this study. Data analysis data collection was done between the month of August and December 2020, and it was done using a pre-tested self-administered pre-tested interview-administered questionnaire that was actually gotten from literature. Data analysis was done using SPSS version 20, and then the data variables categorical variables were summarized as frequency and proportion, and the continuous variable was summarized as mean and standard deviation. Data analysis was done using chi-square test, and this was used to test the association between the outcome variable and the categorical variable. The level of significance was set at p less than 0.05. Ethical approval was gotten from Health Research and Ethics Committee of College of Medicine, University of Lagos. Results. Table 1 shows the baseline characteristics of the respondent. The age range of the respondent was between 30 and 60 years. The mean age of the respondent was 42.4 with a standard deviation of 7.3, and the median age was 42 with an interquartile range of 11. Majority, accounting for about 81.8%, had greater than 6 years of education. Majority also completed secondary school and tertiary school education in this study. Table 1 shows the awareness of HPV infection, cervical cancer, and HPV self-sampling among the respondents. Less than 1/5 of the respondents, accounting for 17%, about 17%, had ever heard of HPV infection. But more than half of the respondents had ever heard of cervical cancer. And about 30% of the respondents had ever heard of screening method for cervical cancer, while about 10% of the respondents had ever heard of self-sampling method for cervical cancer screening, for HPV and cervical cancer screening. This figure 2 shows the proportion of participants advised to screen for either HPV infection or cervical cancer. About 9% of the respondents had ever been advised to screen for HPV infection, whereas about 37% of the respondents had been advised to screen for cervical cancer. About 40% of the respondents had ever had pap smear tests done before. And about 20% of the respondents had ever used any kind of self-sampling kits before this study. And this kit could include like pregnancy test kits that they've all actually used on by themselves. Figure 3 shows the acceptability of self-sampling method for the HPV screening among women in this study. Majority, accounting for 80% of the respondents, accepted the self-sampling kit and actually used it and submitted a sample for analysis in this study. And about 20% of the respondents did not accept the self-sampling kit for HPV screening. Figure 4 shows the acceptability of HPV self-sampling by age category. Acceptability rate was highest among those who are between age group of 50 to 59 years. And it was also high among those between age 30 to 39. The mean age by acceptability is shown at the lower part of this slide. The mean age of those who accepted HPV self-sampling was 42.5 with a standard deviation of 7.4. And the mean age of those who did not accept HPV self-sampling in this study was 41.8 with a standard deviation of 7.0, but this was not statistically significant. Figure 5 shows the acceptability rate of HPV self-sampling by the level of education. The highest acceptability rate for HPV self-sampling among the respondents in this study was found among those who completed postgraduate level of education, and this accounted for 85.7.
Sarah, you have to be winding up.
Those who had no formal education also had the highest acceptability rate. Table 2 shows the acceptability rate of HPV self-sampling based on previous awareness of HPV infection and cervical cancer. The highest acceptability rate was found among those who had self-sample, who had ever had a self-sampling collection method for HPV infection. And this accounted for 93.1%, and that was statistically significant. And also those who had ever had a cervical cancer also had a high acceptability rate of 83.9%, but the significant level was at borderline. Discussion and conclusion. Awareness of HPV infection and HPV screening and cervical cancer was actually low among this group of respondents. About 20%, less than half of the respondents had heard of HPV infection and screening, and about half of the respondents had heard of cervical cancer. This was similar to the findings among the general population in Nigeria, but slightly more than the findings among HIV positive patients that were seen in this same clinic about 10 years ago. And this shows that there could have been increased awareness on HPV infection and cervical cancer. Acceptability rates were high, about 80%, but were unrelated to age and educational level. And this finding was similar to those studies from Kenya, but it was lower than the study from Nigeria among the general population in a community-based randomized control trial, where the acceptability rate was about 93.3%. And this shows that there's a need for increased awareness on HPV self-sampling among the general population and the women with HIV infection. Highest acceptability rate was seen among those who have some form of awareness on HPV self-sampling. Previous awareness on cervical cancer was actually associated with increased acceptance to screen for cervical cancer in a study among HIV patients. There's a need to increase health education on HPV infection and association with cervical cancer. And there is a need to increase awareness on HPV infection in order to increase the acceptability, HPV self-sampling method, in order to increase the acceptability of HPV self-sampling method. And this can be done through provision of IEC material, information, communication, and educational material that can be produced for these patients that could produce to be read by them in the clinic and at the community level. And this will contribute to the elimination of cervical cancer by the year 2020. These are our references. Thank you for listening.
Thank you so much, Adebola. A very interesting presentation, especially as most countries in Africa are moving towards HPV vaccination. And the debate is always on about, is it more cost effective to do that or to just go for screening and improve the screening program? So this is one interesting area of self-sampling for screening purposes. A reminder to everyone, please, if you have any comments or questions, please put them in the chat. And Sarah, you do have a question, so I hope you are paying attention to the chat. Please do answer Marjorie's question, Sarah, from your from the first presentation. Thank you so much for the first two presentations. We will move ahead in the interest of time. Our next presenter is Dr. Omona Kizito, who is presenting on determinants of Caesarean section rates in private, not-for-profit healthcare facilities in Uganda. And to our technical moderators, I did request that you add Dr. Omona as a panelist so that he's able to share his video and his presentation, please. Thank you. Dr. Omona, please, you may go ahead. I will remember you have 10 minutes. When you see me switch on my video, it means you have about a minute left. So do pay attention to that as well. All the best. You are muted, so I don't know if others can hear you.
Yes, hello members. Are you able to hear me?
We can hear you now.
Okay, good morning, good evening members. I am here to present to you. So, I'm here to present to you determinants of cesarean section rates in private not-for-profit healthcare facilities, a study of St. Joseph Hospital, Kitovu. This presentation has, this work has been published, and that is the digital object identifier through which you can be able to get the detail of the presentation of the publication and you read at your private time. Cesarean section, cesarean delivery is the delivery of the baby through incision in the mother's abdomen and the uterus. That is according to American College of Obstetricians and Gynecologists 2017. Cesarean section can be done for a number of reasons. There are so many indications, some of which can be failure of labor progress or obstructed labor, fetal problems, big babies, malposition, and many others. Yes, over the years, the rate of cesarean section has been globally increasing to level that unacceptable did not occur. For example, in a study by Onak, Norman, and Stock 2018, it was reported that the cesarean section rate was at 24% in Western Europe, 32% in North America, 41% in South America. And this is well above the acceptable level of 10 to 15% by WHO. Because of this debate, there has been a lot of advocacies for evidence-based research in order to safely reduce cesarean section rates. A study in Uganda in Bara Regional Referral Hospital one time found the cesarean section rate to be at 24.1%. That was in 2016. Yes, when medically indicated, cesarean section can decrease maternal and newborn death. However, when it goes well above 10%, there is no evidence that mortality will improve. So for the problem statement, for the past 30 years, the recommendation of WHO has been the same, that the level of cesarean section should range from 10 to 15%. And as I've already mentioned earlier, there has been increasing trend in these numbers. And this has become a worrying concern all over the globe. The study had three objectives. One was set to determine the average cesarean section rate in the facility, then to establish the determinants of cesarean section delivery, and as well as examining the attitudes of health managers towards monitoring and evaluating cesarean section deliveries in the facility. The design was descriptive and analytically cross-sectional in nature, both qualitative and quantitative. Mothers were recruited into the study as well as health managers, and a sample size of 318 respondent mothers was established. These are some of the variables. The dependent variables included mother's delivery mode, number of monthly cesarean section conducted, number of total deliveries. Then the independent variables were this. Ethical consideration was taken care of, and data was collected using a document review, guide, observation checklist, interview guide, and semi-structured questionnaires. An analysis was done using Microsoft Excel and statistical package for social sciences. Out of the mothers, in order to determine to get the determinants of cesarean section rates, out of the 318 mothers who were recruited, 92 of them, which is 28.9%, delivered by cesarean section. And most of the mothers were of age category 20 to 40 years, constituting 60.4%. Well, in order to determine the average cesarean section rate, it was computed and found to be for those 7 months, it was found to be 47.6%, which is quite higher than the recommended 10 to 15% by WHO. Then a number of determinants were found. One of them was age. Age of the respondent was found to be a determinant of cesarean section rate with that probability values. Not being married was found to be a determinant educational level of the respondent and also living in urban setting. In particular, also socioeconomic determinants, that is the regular monthly income, was a factor, as well as the occupation. They were highly associated with cesarean delivery. Most especially, mothers who live in urban setting were found to be 2.8 times more likely to deliver by cesarean section as opposed to their rural counterparts. Similarly, respondents or mothers who earn a little higher money compared to their colleagues were found to be having higher chances of being delivered by cesarean section at the 11 times and 2 times more, respectively, more than their counterparts who had lower income. So this is a summary table. When you look through the publication, you can be able to get the detail of the analysis. When we examine the attitude of managers towards monitoring and evaluating cesarean section rate qualitatively, there were a number of themes and sub-themes that were developed, and I want to go through some of the few scripts. For example, concerning thoughts about cesarean section, one of the health managers had this to report. What do you mean? Here we have a team of qualified medical personnel ranging from intern doctors, medical officers, and 3 resident obstetricians. So I believe the rate of cesarean delivery must be okay. Another respondent had this to say. Sometime back, we had a team from Ministry of Health who came for supervision here, and they complained that our cesarean section rate is higher, but it ended there. So I think we are doing well. Yes, there may be slight difference from other facilities. So these were some of the thoughts that came up from the managers. The details you can also go through when you go through the published work. One respondent had this to say, yes, we have a fully functional M&E system. We have used it in many departments, but I don't remember using it for monitoring cesarean section delivery. What does that mean? That means probably the monitoring of cesarean section in the facility is low, and that could directly attribute to the high rate of cesarean deliveries. Yes, the finding is also similar to what has been got in many other parts of the world. There is no much difference. Just like the finding in this study was the cesarean section delivery rate was high, in many other studies across the globe, it has also been found to be very high. So therefore, if we are to conclude, does that mean the social justice? Certainly no. There may not necessarily be social justice. In recommendation, my recommendation was based on the work of WHO 2018, which still maintained the initial recommendation that they came up with. In this case, it is related now to improving on certain aspects in order for cesarean section rate to remain at 10 to 15%. This includes educational intervention for women, use of clinical guidelines and second opinion, use of clinical guideline audit and feedback, use of collaborative midwifery obstetrician module of care. You can read about that care later. Financial strategies, monitoring and evaluating cesarean section, and also developing standard guidelines that can be used across in the facilities. This is what I have for you. Thank you so much.
Thank you so much for the presentation and sticking to time. You just had under a minute left, so very, very good timekeeping. Thank you so much. I think interesting results raise a lot of questions. I'm sure people will have questions for you in the Q&A, but very interesting results. We are doing okay on time, but we don't have too much time before we have to wind up. I think we have about 10 minutes. So we shall move straight ahead to the next presenter, who is Peter Dejene, and he is presenting on lay first responders, and he has a model to share with us. I will let him read the rest of that title. So Peter, please, you can start now. You have 10 minutes. Please go ahead.
Thank you so much, Moses. And thank you to all of my friends and collaborators who are on the call today, both from the University of Michigan and abroad, namely Zachary Eisner and Dr. Raghavanjan as well. So today I'll be presenting the lay first responder model, which leverages pre-existing transportation providers to deploy pre-hospital emergency care programs in resource-limited settings. So these are my personal disclosures. I'm the executive director of LFR International, which is a nonprofit that researches emergency medical development in resource-limited settings of sub-Saharan Africa, as well as a researcher at the Michigan Center for Global Surgery. So a little bit of background about injury is that it represents about nearly 10% of the world's annual deaths. Unfortunately, this is disproportionately borne by low and middle income countries. That's actually 90%. And the largest driver of that global injury burden are road traffic incidents, including traffic accidents. And you can see here in the bottom right, road traffic injuries as a whole have been increasing as a leading cause of dailies globally from 1990 through 2020, with increases in motorization of low-income countries. So a little bit of background before we discuss the model. Transportation in sub-Saharan Africa is often dominated by what are known as motorcycle taxis. And they go by many names locally, whether it's boda bodas in Uganda or okadas in Sierra Leone. They're a predominant form of short and intermediate distance transport and have often been seen as a bottom-up response to a lack of government-funded or affordable transportation alternatives, because they provide door-to-door service, can operate in areas with limited road infrastructure, as well as are fairly cheap to purchase compared to alternative four-wheeled vehicles. They've been found as well in a majority of sub-Saharan African countries. Actually, a sample of 203 cities of greater than 100,000 people found that they were reported in over half. And unfortunately, their proliferation as a transportation alternative has also been tied to an increase in road traffic accidents. And so many of these settings that disproportionately bear the global injury burden are also least equipped to deal with it. And that over 90% of the African population has no access to emergency medical services or ambulatory options. As a result, about 80% of injury-related deaths occur in the pre-hospital setting, compared to just 59% in higher income country settings. And it's been said in disease control priorities that up to 45% of all deaths might be addressable with emergency medical service expansion. So unfortunately, it's not just as easy as replicating models that exist in other countries in these settings. When that has been attempted, it's failed, namely due to financial limitations, infrastructural limitations, and then a lack of insurance or reimbursement models that can support payment for emergency medical providers. As a result, a lot of the development we've seen, both on the African continent and abroad in other low and middle income countries, has been quite varied and heterogeneous. And there's no consistent blueprint that's been discovered or reported, which can be followed to formalize emergency medical services. However, since 2004, the World Health Organization has recommended that training bystanders or lay people should be the first step toward formal EMS development. What we think we've discovered is now a model that others can follow to systematically scale up emergency medical services from an informal lay first responder model into a formal sort of paramedic-like model. And that is through training pre-existing motorcycle taxis to provide that pre-hospital emergency care. We started these programs in 2016 in Uganda and have since studied the model in Chad, Sierra Leone, and are beginning studies in Kenya and Nigeria this year. Our course comprises many of the, it's a 5-hour course actually. You can teach it in 1 half day, and it comprises 4 or 5 main curricular components, including scene safety, general ABCs, fracture splinting and immobilization, as well as safe victim transport. You can see here in the right column some of the deviations from traditional high-income country curricula as well. The cost, I know there's a lot presented here, but the main takeaway is that we're also able to do this affordably. So for every 6 months, on a per responder basis, it costs about $6 US. So that comes out to about $12 per participant per year. And you can see in the left side table some of those components of those first aid kits. When we've built out cost effectiveness analyses, we found that for a group of 100,000 people, it costs about $12,500 annually. And that both comprises training costs as well as first aid supply costs. When you model out those cost effectiveness ratios with the road trauma related disability adjusted life years, using the traditional cost effectiveness ratio model of cost divided by disability adjusted life years averted, we find that the price is about $53 per daily averted, which falls somewhere between some other sort of preventive measures to increase road safety, from $4 from the bottom sort of parameter being $4 for speed bumps, up to about $3,500 for helmet legislation. And then under the World Health Organization's Food Choice program, or choosing interventions that are cost effective, which advises that any ratio less than a GDP per capita is considered highly cost effective. We found that even in consideration of this number in context of the lowest African GDP per capita, which is Burundi, about $260, we still find that this value is lower than that value, suggesting that training lay first responders to address road trauma in sub-Saharan Africa is highly cost effective per these World Health Organization guidelines. And so we've also studied the model in regard to the participant knowledge, both their acquisition as well as their retention. You can see here, this was a study we did with about 2,000 lay first responders we trained in Sierra Leone. You can see that between both the pre and post-test columns, knowledge significantly increased. But the more important part is that it was retained. At 6-month value, it had slightly decayed, and by 9 months was returning back toward a baseline, suggesting that 6-month intervals of both resupply as well as refresher courses are suggested. When we've also tracked patient impact, we've been very pleasantly surprised. Part of the course is safe victim transport, and that's transport using a motorcycle. And a lot of people are very surprised when we discuss this, but we've come up with a list of contraindications of when somebody can safely be transported on motorcycle. And so the cases in which one cannot be transported are when there's altered mental status. So if the patient's ever been unconscious, if there are double lower extremity fractures, if there's any suggestion there might be pelvic instability or pelvic fracture, and if there's any concern for a spinal injury. But when the model's actually been tested in West, Central, and East Africa across over 2,000 patient encounters, we find that over 90% of the time we're able to transport patients safely by motorcycle, which has avoided extremely costly infrastructure spending on traditional box ambulances you might see in a high-income country setting. And so we've also followed up the model at both 3-year intervals as well as yearly intervals in some of the countries we've conducted this work in. And we've been really very pleasantly surprised to find that over 3/4 of those initial trainees that we've trained in these settings are continuing to participate voluntarily after 3 years. And this was a really surprising finding that we had. But when we followed up qualitatively, we found that there were a number of factors that were encouraging this. Primarily, it was new knowledge and skills, sort of an altruism component as well. But there was also a gain in social stature tied to this ability to not just be seen as a first aid provider, or not just a transportation provider, but now a lifesaver, which increased their customer acquisition as well. So they ended up earning nearly 25% more than untrained counterparts. You can see here a quote from one of our trainees as well. But this has encouraged them to remain involved and continue to promote these programs. When we've evaluated the program as well using a new tool we call PETCAT, which looked at quality indicators and independent assessment by healthcare professionals who are on the receiving end of these patients, we found that care has improved dramatically from on a Likert scale of 1 out of 10 all the way up to 5 out of 10. And so in conclusion, what we're seeing is that the injury burden from road trauma is extremely high across the country. And simultaneously, access to pre-hospital emergency care as well as transport is very limited. But thankfully, motorcycle taxis are prevalent, and what we're demonstrating now is they're able to be trained. And so training motorcycle taxis as LFRs to address road trauma is both highly cost-effective as well as a lasting intervention because of this social and economic mechanism that's incentivizing long-term voluntary participation. And so we're now studying the model, again, as I mentioned, in Nigeria and Kenya this year, but are also hoping to study it in alternative settings on much larger scales as well. So thank you all for listening to the presentation. Be happy to take any questions as well, if time permits. Thank you.
Thank you so much, Peter. Quite a comprehensive presentation with so many ways you've triangulated the data. I'm especially interested because my current area of specialization is economic evaluation and cost effectiveness studies. So I'll probably get in touch with you separately to follow up on some of your methods and so on. We are at 16:45, which is our end time, but I would like to hand over to my host, who is Judy. Judy, are you still on? You can help us to close the session.
Thank you, Moses. I was diligently following the presentations, which was so rich, very, very much contributing to knowledge on the continent. I know we are at time slightly over, but if we can beg your indulgence to take maybe just 5 more minutes. There was some questions which came in, and I'd just like to give an opportunity to Sarah Kiguli to answer one question that was directed to her. Please, Sarah, if you can, that would be lovely to hear your voice and for participants to hear what you have to say. I think you have seen the question, Sarah, isn't it? Is Sarah with us?
Yes,
so
I had forgotten to unmute. Thank you. Thank you. There were several questions, so I don't know which one I'm going to answer, to respond to. But there was a
question on the challenge, the measures we can implement to mitigate the challenge of the huge numbers of students.
Okay, huge numbers of students, yes, a very big challenge. And competence-based education also being at requiring a lot more time. I think I don't know how to mitigate the big numbers, but I think that even with the big numbers, with proper organization and coordination and breaking the big number into small groups so that students can learn better, there's more interaction, I think that helps. But we as faculty should be trained in how to facilitate small group learning, but also learn how to go with the outcomes of every training session in mind, as opposed to the content. And formative assessment and learning how to give feedback helps. I think that's what I can say now.
Thank you, Sarah. I'll move over to Adebola. There was a question that came in in the Q&A box around sensitization. I see that you've answered it, but you can also just take a minute for us to hear your voice and have you answer that. How has your study helped to scale up sensitization? And you were talking about awareness of HPV infection.
Yes, thank you very much for that question. Just like I mentioned, this particular presentation is part of the bigger study that we actually conducted. Because in this study, this was just like a baseline findings of the awareness of HPV infection and self-sampling. So we developed training materials for these women on HPV infection and cervical cancer, and also actually trained them to see the effect of that. We plan to recommend this training material to be used in our clinics subsequently to be able to educate women on HPV infection and cervical cancer. So that's a very good question that we wish to scale up the intervention at our own setting and also even other settings around us in Nigeria so that we can use that material to be able to educate them on HPV infection.
Thank you so much. And Peter Delaney, thank you for your LFR model. I think you've seen colleagues from Africa reaching out to you. So I think today you'll go home a happy man. And I believe Moses and the colleagues that are interested in what you had to say can take the conversations forward. I want to thank you so much, all of you, once more, for taking the time to give us your information, your findings, your recommendations, some of the challenges you faced. I think for me, just to quickly summarize this session, the IP interventions that have come across through the 4 presentations we've heard this afternoon really speak directly to equity and social justice. I was especially touched around the issue of Caesarean sections as a woman. And I know that this is increasing and really should not be the case. So Dr. Omona, I really thank you for that information around CSS for us women, especially here in Africa. So these recommendations are very timely. They speak directly to justice and social equity. Your LFR model, Peter, is excellent. I'm glad to hear that you've been able to persist despite some of, I can imagine the terrain challenges you face, and I would urge you to go, for example, to Lesotho, that mountainous kingdom, and see how much you can do, because I know one of the challenges is our terrain and our remoteness and rurality. So it's great to see these interventions happening, and also to know that many people, often we always think of the medical side as medical people and forget the trauma that comes as a result of these accidents that we all face. And even to you, Adebola, around HPV, excellent information around sensitization. And again, through these mechanisms that you are putting forward, I think we are really moving in the right direction around social justice and equity. I want to thank you so much for your outstanding presentations. I want to thank you for your time. I thank you, Secretariat, for the support to have this up and running. And to my co-moderator, Moses, always a pleasure to work with you. I always get excited when I see your face. It's lovely to have done this together. I know we are slightly over time, but colleagues, I thank you. And I want to bring this particular breakaway session to a close. Thank you, everybody, and have a good rest.
Thanks, everyone. Bye-bye.
Bye-bye.
Thank you. See you in the other session.
Bye-bye.
Bye.
On